Today, I am going to be doing a video on documentation. Hello, and welcome back to my channel, Mental Health with Melissa. I'm Melissa. I am a licensed clinical therapist, more specifically an LCSW in the state of California. Before we get started, please do not forget to hit that like and subscribe button for more content like this. I post videos every single Wednesday and Sunday. Subscribing to my channel really helps me get mental health information out there to our communities of color and to those that are interested in the mental health professions, particularly those that are interested in becoming licensed clinical social workers or any other type of mental health providers, really. I do a lot of videos on LCSW test prep and mental health psychoeducation videos, and today I am going to be doing a video on documentation. So if you are interested in watching, please stay tuned. I got this idea from somebody who left a comment, and I thought that it was a really fantastic idea for a video because as a part of the mental health profession, a huge portion of our job is documentation. Documentation does so much stuff. It helps communicate to other providers what our clients are going through, how they're coping, what their presentation is like, and it also helps us as the clinicians and the providers by letting us know what is going on with the client for that day, comparing the overall presentation of our client from the last time that we saw them in the last sessions and comparing notes from previous sessions. And it also helps us with billing insurance companies if you work for either private practice or an organization that bills insurance, because it helps them understand why your client needs a particular treatment, and then therefore the insurance covers that. So let's go ahead and get right into it. Again, this is a really important topic. So there's a few disclaimers before I get into the meat of it. So as you see here, every organization is different. And so you're really going to want to check with your organization, your supervisor, your clinical supervisor or administrative supervisor on what your policies for documentation are, because there's really no one size fits all approach for documentation. Governmental agencies, state agencies, private organizations, all of these organizations and entities document in their own specific way. And so you're going to want to learn and follow up with those particular guidelines for your employer because it's so different. There are some similarities in kind of general rule of thumbs about documentation that we're definitely going to explore today. But if we're talking about specifics, like the documentation format, what the content of your note looks like, and things of that nature, that's really going to differ from company to company, organization to organization, practice to practice. So again, definitely follow up with your organization's policies on that and check in with your supervisor or manager if all else fails and you don't have like a standard operating procedure for that. And then another thing is a really helpful tool is being able to read and learn descriptive assessment words. So what do I mean by that? Even though I'm going to go over some examples of how to document and things of that nature, it's really going to help if you do some reading on your own time about how to describe how a client is presenting. So key terms may include things such as what does alertness and orientation mean? What does thought process mean? Hallucinations, ideations, things of that nature. You would be surprised, a lot of people don't fully understand what that means, and that's okay, but it's really important that you follow up and learn about that yourself. Just as another side note, so I am, like I said, a licensed clinical social worker. I'm a clinical supervisor. So what that means is I provide supervision to associate social workers that want to get their hours. So I meet with them a couple times out of the week. Usually it's just one time a week, but I have to co-sign all of their notes. So I have quite an extensive history in the past few years of co-signing notes, making sure that there are certain things that we follow up on with notes, and just making sure that everything is documented appropriately. And again, that things are really followed up on, because at the end of the day, when we have our license, we can be liable for certain things. So I just thought I would add that in there as a separate thing, because again, I've been doing documentation since 2011, I want to say. Yeah, since 2010, 2011, I've been doing documentation as a mental health provider. So I do have quite a bit of knowledge in doing it through the school district under a psychiatric school social worker, in the hospital setting, in the hospice setting, in the mental health clinic setting, and in private practice. So again, all of these places had such different ways of documenting, so I cannot stress enough how important it's going to be to follow up with your specific job's organization policies. So let's go ahead and get into the content. So what we're going to be looking into is what we call SOAP notes in the mental health, behavioral health field. Now, in one of the programs that I work at, we don't do SOAP notes. It's a little bit different, but generally speaking, SOAP notes are usually a kind of universal way of learning how to document as a mental health and behavioral health provider. So I thought this would be kind of a good way to introduce some documentation to you. And basically, a lot of different professions use SOAP notes. So it can be a clinician, a therapist, a doctor, occupational therapist. So people with these types of profession usually use SOAP notes. So we're going to go into the details of this, starting with this subjective. So SOAP is an acronym for subjective, objective, assessment, and plan. So we're going to break each of these down. So first, the subjective. So the subjective, you're going to want to describe your impressions of the client in the subjective section. So in this section, you're going to want to put down quotes of what they discussed and what they talked about during the session. So as an example here, you see that the client appeared alert and cooperative. He stated, "I'm ready to work hard today." So the reason why we do a subjective portion is because we want to be able to notate how the client presented and what their reports were in the content of the session. And we definitely get into the objective and our assessment and evaluation of the client. But just like it's important to evaluate how they are doing from how we're seeing and observing the client, we also need to be able to document and put down how they present to us from their perspective and how they are seeing or describing how they are seeing how they're doing that week. So I'm going to give you an example for subjective. So this is an example of a client. This is a made-up client. This is not a real client, obviously. So client states that he had a hard week. So you notice how I put hard week in quotation marks. So I'm taking a comment that the client said and placing that in the subjective portion of the note to kind of justify where the client's at based on his own words. And then I further elaborate on that by stating what he states. He states that he was fired from his job, and as a result, him and his family had to apply for food stamps. So we're giving the reader, which may be another provider or ourselves, when we kind of look back at this session, if we're later down the road in a future session, to see what exactly it was that he reported gave him a hard week. So he was fired from his job and he had to apply for food stamps. So that was part of it. Now, we don't have to put all of that in quotes. If we choose to, we can, that's fine. But we can also condense that into a more simplified version of what he said by still expressing that our client stated that. So to kind of further that, client endorses feelings of sadness and lack of sleep. So endorses is another clinical way of just saying stated. So when we say endorse, we're pretty much letting, again, the reader know, or our future self know, that the client was expressing these feelings. So this isn't yet our assessment. This is what the client was endorsing to us. And request information on mood medication. So again, that's what the client stated. So next is the objective. So the objective part of the note is where you want to write measurable information. So data can go there if you are a psychologist, or if you do any sort of intelligence tests, things of that nature. You can put test scores and stuff of that nature here. So if we're continuing on that same client, that same example client, the objective for that client would look something like: client's eye contact was appropriate, although he has experienced multiple losses this week. He continues to maintain significant relationships with his family. He appears fatigued, as evidenced in slumped posture, and emotional due to crying throughout session. Appears to rate mood 2 out of 10, which has decreased since last session, and lack of progress regarding mood improvement treatment goal. So right away, we can see here that this is starting to get more along the lines of evaluation and assessment. Now, we haven't got to assessment yet, and you'll see shortly what the difference is between objective and assessment. But with subjective, we saw that we're really making sure that we're putting down the client's reports and their quotes and statements and what they're expressing and endorsing. Now, under objective, we are again putting down, like the last slide showed, we're putting down more measurable things that we've observed. So if I met with the client last session, and last session they reported to me that he had a 5 out of 10 mood, 10 being the best mood, and 0 being the worst mood. So 5 was in the middle, and then he went down. So that's showing us a very measurable type of documentation here. And that's why we do this, because we want to be able to track where our clients are at. So that's an example of objective. We also see that the eye contact was appropriate. So we're, again, making a comment based on more objective measures as opposed to what's going on subjectively with the client. So the assessment part is where you're going to want to get creative and provide more detailed information about your overall evaluation, about how your client was presenting. If you're working for insurance organizations or agencies, or you're in private practice, then you're going to need some evidence to show that your client meets criteria for a particular diagnosis. So this is going to be a very important part if you're working with insurance companies. So for the assessment part, Mr. Smith is a 54-year-old Asian American male who resides with his wife and 2 children. So for the first sentence here, we call this part, or for the first 2 sentences here, we call this part a case presentation, or for those that work in the medical field, an H&P. H&P stands for history and physical. We want to make sure that we put down the age, the race that the client identifies as, the gender that the client identifies as, where they reside, who their support system is that they reside with, what they are diagnosed with. He is diagnosed with major depressive disorder. He has been experiencing difficulty concentrating and trouble sleeping for the past 3 weeks. So the reason why we put this, we already have that he's diagnosed with depressive disorder. So why do we need to put he has been experiencing difficulty concentrating and these other 2 things when we already know that he has major depressive disorder? So if we're taking a look at what the criteria is for major depressive disorder, 2 of those things are difficulty concentrating and trouble sleeping. And if we know more about major depressive disorder, symptoms like this have to be present for at least 2 weeks. So we see that these symptoms have been present for 3 weeks. So this is really important information to know, because if the insurance company is asking for justification about this diagnosis, we can say it's right here where we documented that these are symptoms of what they were dealing with and the duration. And so that's why they meet the criteria for major depressive disorder. So if you're interested in learning more about diagnosing for your LCSW exam, because there's a lot of questions on the LCSW exam about diagnosis from the DSM and symptomology and criteria, I do have a video, I'll link it down below, about diagnosing. So this is very important to know. As therapists and clinical social workers, we have the ability to diagnose, and we need to be very intentional when we do it. We don't want to just be labeling people. We want to be taking into account what their symptomology is. Alert and oriented times 4. So because I don't want this video to be too long, I'm not going to go over in detail exactly the terminology of all of these things. So I do highly recommend, like I mentioned in earlier in this video about disclaimers, about if there's something in here that you don't understand, Googling it or following up with a supervisor or reading more about it and terminology so that you can implement them and understand what you're writing in your clinical documentation. But basically, orientation assesses being oriented to self, place, situation, and time. And so if they're times 4, it's great. If not, then we need to assess further and really determine if it is ethical to be having a session with them based on how they're presenting, if they have altered mental status, disorientation, things of that sort. We want to assess for mood, congruent affect. So that means, does this person, what they're reporting, does their presentation and behavior match up? You know, an example is Mr. Smith tells you that his cat dies, but he's laughing and he wants to go dancing. Now, that would be incongruent. Speech, we want to make sure that their speech is how it normally is, and if it's not, if that's their baseline. Language, are they able to express themselves based on what their language is? Thought, content, and process appears linear and logical. If they are going on tangents and not answering questions, or are in a manic state, then this is not going to be linear and logical. So linear and logical means they're really able to have this this very straight and forward type of thinking process. Auditory and visual hallucinations, I really highly recommend that you look more into what hallucinations, psychosis, or delusions mean. Those are going to be very important when you're working with individuals and assessing them. So in this example client, he denies any auditory or visual hallucinations. Auditory hallucinations are hearing things that aren't there. Visual hallucinations are seeing things that aren't really there. SI means suicidal ideation. HI means homicidal ideation, and appears future-oriented as evidence in his plans to find employment and visit his parents in the next month. So why is it important that we put as evidence by, even though I already said that he denies any SI, HI? And the reason why I did that is because if he has major depressive disorder, then he is likely at an elevated risk for having feelings of hopelessness and thoughts of SI. So we want to make sure that we make it very clear that he has plans, and he does not have any thoughts of harming himself. And if he does, then again, most of us as mental health and behavioral professionals, if not all of us, are mandated reporters. So that would be something that you would need to turn to your state guidelines about what you would have to do in that scenario. His insight and judgment appear good, as he has an understanding of how his job loss was major. Sorry, there's a little bit of a typo here. Here he understands and he comprehends the meaning behind this, and he's kind of coping, worse than maybe somebody that doesn't have major depressive disorder would, but still that's a major loss. So he has comprehension into that. So mood has decreased from a scale of 5 out of 10 to 2 out of 10 since last session. So if we're looking at a mood scale, 10 being the best mood, 0 being the worst mood, if we're looking at the last session, again, this is why documentation is so important, because we can look at our last few sessions in our documentation and see that, because we may not remember, he reported us a 5 out of 10. We documented that. Today he reports at a 2 out of 10. So if we're putting this in our treatment goal, if he visited us for the initial assessment and in the treatment plan, he says that he wants to improve his mood, then this is going the opposite direction of what the treatment goal is. So it's going to be important to monitor that. And that's what we put here, and we'll continue to monitor throughout treatment plan. Okay. Now, plan is the last part of documentation. Outline the course of treatment in the plan section. So any changes to objectives, activities, reinforcement schedule should be included. So here we see the plan for Mr. Smith is to continue treatment plan. So if you did, we're making an assumption here that this SOAP format is going to be the documentation that you use later on, because there are initial assessment templates that are more thorough, that have like a more psychosocial historical component when you really assess a lot more about the psychological, biological, and social aspects of your client. So in that, we're making the assumption, hopefully, that you were able to create some sort of goals with the client and treatment plan. And so we want to make note that we're doing that. Monitor the mood. For this particular client, this is going to be very important, because that's what their presenting concern was in this objective. Their mood is low. And also in this objective, they had mentioned that they wanted more information about mood medication. So that's out of our scope of practice as therapists, whether you be an LCSW, a psychologist, LPC, LMH, PsyD, whatever. We're not MDs, we're not RNs. So although we may have an understanding of psychotropic medications, we cannot give advice on what types of medications that our clients take. So we always want to provide a referral. So here in the plan, we can also do the resource coordination. And in this case, it was referring the client to a psychiatrist for appropriate level of care, appropriate scope of practice sort of needs. So that was it in a nutshell. I tried to make it as, brief as possible, but considering that documentation, again, as I mentioned earlier, is like the templates and the format is different based on where you work, you're really going to want to follow up on that with your organization, your private practice, whatever. But these were kind of the bare minimum basics. And before I end, I did want to address one part of the question in this comment that this individual wanted to talk about, which is kind of keeping up with notes and documentation. Because another part of documentation, if you have a large caseload, whether you be not licensed or if you are licensed, it can be very challenging to keep up with all of your notes. So a basic rule of thumb may be to try to get your notes done as soon as possible. So if that means you have a little bit of a break before your next session, then just try to get that note out right away, right after you see that client. If you have clients back to back and you're not able to write the notes for the day, then try to do it at the end of your day. The rule of thumb is really to make sure that you set aside a certain amount of time, and only you know how much time that is, because some people write notes really fast, others write notes, it takes them a lot longer. So if that means you need to set aside a day of the week, if you have the ability to control your schedule, where you just set aside one day to do complete all documentation at the end of the week or at the beginning of the week, or 1 hour out of your day to do documentation, it really depends on you and how you're able to manage your time best. But again, the rule of thumb to make sure that you keep up with all of your documentation and notes, and not to get backed up on all of those notes from your cases, is again to just set aside that time, do it as soon as possible so that you don't forget some key things that happened in your sessions. What you can also do is have a template for your SOAP notes, and so that you have it all already written out and you just change the assessment portion based on how your client was presenting. So you can copy and paste a majority of that template into each note. But if you have any questions or you have some comments of your own regarding documentation, please leave them in the comments section below. And again, please don't forget to hit that like and subscribe button for more content like this. Until next time, managing mental health matters.